Today, I am going to talk about a concept which is usually ignored by us as a gynecologist. But the future is not far away when this will become one of the most important aspects to be addressed in our clinical practice. It's about sexual dysfunction and quality of life. In this lecture, we shall discuss about various aspects of pelvic organ prolapse and related sexual dysfunctions. It was just last year, the month of February, I vividly remember. Just like this, a man was shouting and fighting in our OPD. His wife had undergone VH and repairs for prolapse just 2 months ago. Agitated and angry, this man now wanted all the sutures to be removed, and he said that make it like earlier before. I don't know his age, but his wife was 60 years old. Going back 20 years, I was in second MBBS, posted in surgery. Suddenly, a man enters the OPD and starts abusing the head surgeon, which was too shocking for me and my friends. Later, we came to know that this man had undergone prostatectomy for benign prostatic hyperplasia, during which his nerves got damaged, which is probably a known complication leading to erectile dysfunction. This man was 70 years or maybe more. Talking about the younger generation, a few years ago, my nephew told me a teenage joke. A boy who had recently started smoking bought a pack of cigarettes, and while returning back from the shop, he was just reading its cover. Now you must have seen the warning on the pack of cigarettes. It says different kind of things like smoking kills, smoking causes cancer. But this pack which he had bought today read smoking can cause sexual dysfunction and can make you infertile. The boy turns back, runs to the shop and tells the shopkeeper, still panting, that please give me the pack that causes cancer. I don't want this one. So, what I mean to say is that across all ages, across all generations, sexual functions have been an important part of our lives. We can keep our eyes shut, but the truth will prevail. All three stories that I told you were about men. Maybe in our socio-cultural ecosystem, women do not talk much about it loudly. That makes it even more important for us, the healthcare providers, to understand their needs and make them speak. And with this background, let me ask you two questions at the outset. Number one, how many of you ask your patients with prolapse about sexual dysfunction? And two, how many of you think about sexual functions in your operation theaters while you are performing various repairs? You don't have to give me any answer because probably you and me both know it. So let's start afresh from this paper which was published in the year 2020, just a year ago, in Nature, about pelvic organ prolapse and sexual functions. One of the most prestigious journals in health sciences, Nature, being addressed by Nature itself, reveals the growing significance of this topic. The review entitled POP and Sexual Dysfunction talks about various issues which must be considered in day-to-day clinical practice while evaluating these women. What I'm going to do that I will try to focus on some very important points which were discussed in this review article. First is what effect pelvic organ prolapse can have on sexual functions. Now, it is a very complicated question, as human sexual functions are complex and depend on so many variables like socio-cultural beliefs, interpersonal relationships, environment, self-image, mood, and many more. But as a whole, It has been seen that around a third of women having uterine prolapse will have sexual dysfunction as their major concern. Researchers have reported two important confounding factors that make this estimation very difficult. First is that all women who present with prolapse are actually not sexually active because of various reasons. And the other important confounding factor is presence or absence of urinary incontinence. Actually, this one is a big factor responsible for sexual dysfunction or sexual inactivity in women. These biases make it more complicated, but in a simple way also. The assessment of sexual function is not easy as we are not specially trained to take care of this domain. The simplest way will be to administer a questionnaire. Talking about the questionnaire, we do not have much choices when it comes to Prolapse specific tool for assessment of various quality of life and sexual function domains. The first such problem specific tool was introduced in the year 2001. That's called PISQ, where P is for prolapse, I is for incontinence, S denotes sexual functions, and Q means questionnaire. Later in 2013, it was modified by IUGA, and the revised version is known as PISQ-IR. IR means IUGA revised version of the questionnaire PISQ. This one also includes rectal or anal symptoms and takes care of those women who are actually currently not sexually active. PISQ-IR is presently the gold standard for the assessment of female sexual functions in women with female pelvic disorders. The details can be found at the IUJ website, and as there are not many translations of this questionnaire, maybe this can be a topic for your next thesis or research where you would like to translate and validate the questionnaire in your own language, and the publication you can send it to IUGA. These kind of validated tools, if we are translating it, hope you know they get easy published and they have really high impact. If we look at it, the assessment of sexual domain in women during their evaluation when they present to us first is still easy when compared to the assessment after they have undergone a repair or a surgery. And this has been one of the most challenging and controversial topics in urogynecology. This is because of development of new symptoms after surgery, which are not always easy to define. Usually, the scoring system don't individualize these de novo symptoms but gives a global score. More than that, to quantify and compare the procedure based on this domain is very cumbersome as we do not have one standardized surgical procedure for prolapse. What we do is multiple mix and match procedures for different individuals. Last but not the least, again the show culture bias about sexual activity and pattern makes it difficult to compare and translate the results of one population into other. These de novo symptoms post-surgical repair include de novo dyspareunia, shortened vagina, tight vagina, scarred vagina, and hyspareunia. That means pain which is felt by the partner while having sexual intercourse. This terminology has been jointly given by IUGA ICS, and these societies recommend specifically asking for these symptoms to the patient after prolapse surgery. When we are talking about the post-operative sexual outcome of women who had undergone surgery for prolapse, I would like to talk also about this very recent systematic review. Herein, 77 studies were included, and it is one of the most recent and robust review of all trials comparing changes in sexual functions after prolapse surgery. This review also concludes an overall positive outcome after surgery as far as sexual functions are concerned. However, seeing the variations and disparity among various available studies, the authors also suggest that standardized incorporation of sexual health outcome should be done in prospective trials, which will be much more meaningful for clinical decision making. Now, when we are on board with the surgical management of prolapse, I would like to talk about effect of hysterectomy, or the talk of the town these days, that is the concept of uterine conservation in prolapse. If we look at the face value, it looks like uterine conservation, or at least the preservation of cervix, will help in sexual functions. At least this is what I thought. The recent research, however, shows the results which are contrary to this imagination. One such study that I am showing here, the first one, shows hysterectomy versus uterine conservation for prolapse. And it proved that there is no difference in sexual perception or functions afterwards, whether you remove the uterus or retain it. The second paper is a paper for benign gynecological conditions where one group had total and the other had subtotal hysterectomy. That means they conserved the cervix in these women. Even this kind of comparison also had proved recently that preservation of cervix, as we used to think, does not show any advantage in improving sexual functions. From starting, we have been talking about the women and her sexuality and its concerns. But let me remind you that it takes two for the act. What happens to the male partner when his wife develops prolapse or undergoes a corrective surgery for the same? This is actually going back to the same practical situation from where I started my talk today. So, this group of researchers from Switzerland tried to delve deep into this very question. And as you can see here, they found that after prolapse surgery, even the male partners, for them also, all domains in the said activity showed improvement. So, one question is sorted out. Surgery improves the overall sexual functions in the lady as well as her partner. Though this kind of surgical correction might lead to some de novo symptoms, which we have to always keep in mind. But as we know, surgery is not the only treatment for prolapse. The first line in many patients, we choose to give pelvic floor muscle training. What's about its effect on sexual functions? So I quote here this randomized controlled trial from Iran, where one arm, that's A, underwent surgery and the other arm B underwent pelvic floor muscle training for 8 weeks. They found both the therapies improve sexual function overall. But one point that strikes my mind is both the treatment worked on different domains. Physiotherapy arm had better score with orgasm, while surgery had better libido and better arousal. My point here is I never see these two treatments as different or separate entities. They are, according to me, complementary to each other, surgery and physiotherapy. That's what we have started to integrate in our clinical practice of urogynecology now. Physiotherapy, believe me, is an integral part of management of all or most urogynecological issues. I feel that's how we can give a holistic care, the optimal management to our women. So, a word about integration. After 2 years of starting our urogynecological clinic, we realized that the need was to bring on board a dedicated physiotherapist and a clinical psychologist. And since 2019, in our medical college, we are working this way. This is not just I'm saying that there, but there is evidence also that highlights the need of integration of all these departments in a good urogynecology practice. When we bring others on board, that does not take away our responsibility as surgeons. So, what can we do as gynecologists or as surgeons to be the best and give our patient best possible outcomes as far as their sexual functions in prolapse is concerned? Let's discuss that. So, first thing first, when you are operating, always think of sparing the nerves. As we say, the vascular bundle is around 9 and 3 o'clock position. Similarly, the nerves around any hollow organs run at around 2 and 10 o'clock positions. So try to minimize dissection there. Always keep in mind coital incontinence, as I have told you before that it is one of the most important deciding factors whether the lady is having sexual dysfunction with prolapse or not. If you have found it in your history, confirm it with examination and then tape it when you are performing the reconstructive surgery. One of the most important point I feel while you are performing a surgery is saying no to levator plication. It definitely and definitely causes dyspareunia and rectal symptoms, stool impaction. Provide length. How? Especially by apical fixation, either by sacrospinous one or better with uterosacral ligament suspension, because that will give more symmetry to the vagina. Very important is to integrate physiotherapy and psychological counseling in your clinical practice. Add local estrogen if the lady is menopausal. And last but not the least, assess every patient of prolapse who comes to you and generate data of our own population and publish it so that the generation next or the younger people can learn it and try to change their clinical practice according to it. Let me also remind you today that our job doesn't finish just after surgery. Follow up is equally important. And this is here, the very recent, this month only, this study was published in the Green Journal telling about the women's experience of their first sexual encounter after they had undergone pelvic reconstructive surgery. These women were so full of negativity and concerns about the impact of surgery in their sexual function. So, this article summarizes important points what we must keep in mind when we are seeing the patient during their surgical follow up. First, the return to sexual activity after surgery for POP represents a great unknown for many women. Here, we can play an important and influential role in telling them about their initial postoperative sexual encounter timing. Frank counseling about patient and their partner's fear regarding the effect of repair or reconstruction on sexual activity, as we tell them, will definitely improve their outcome. Remember that the patients are changing, their lifestyle and concept of quality of life is also changing. So, for us also, it is the time to take a leap from complete anatomical correction to giving importance to improvement and quality of life. Thank you.